recording for this meeting has begun.
Well, good morning, everyone. This is Brenda with the Wyoming Primary Care Association. So glad to have you join us. And we are pleased to be able to offer this fantastic training again by Jennifer Davis. We originally broadcast this webinar on October 5th, and we had such great turnout, and a lot of folks weren't able to join our call or to hear the presentation, so we're repeating it this morning. So thanks, Jennifer, for being so accommodating. Just a quick intro on Jen. Jen is a 2001 graduate of Northern Arizona University with a doctorate in physical therapy. She has practiced primarily as a pediatric physical therapist in Arizona and Wyoming since that time. She also has experience in geriatric, outpatient, and neurological rehab. Jennifer currently specializes in preterm infants and children with disabilities. In 2012, she embarked on a new career in child advocacy as the director of the Wyoming Citizen Review Panel. This new endeavor has led to opportunities in advocacy related to the child welfare system, ranging from primary prevention to specialized intervention services. Jennifer has had the opportunity to manage the Prevent Child Abuse Wyoming program and a Parents as Teachers Home Visiting program. Jennifer provides trainings across the state related to child development, safe sleep, ages and stages, developmental screening tools, and healthy moms, healthy babies. Jennifer is an adjunct professor for human anatomy and physiology, as well as medical ethics at Laramie County Community College. Recently, she had the opportunity to become the consultant for the Wyoming Children's Trust Fund. She is enjoying the challenge of advocating for prevention efforts to drive our systems across Wyoming. Jennifer enjoys spreading her passion for prevention of child abuse and neglect across the state in an effort to improve family stability. And Jennifer, I'm going to go ahead and turn it over to you.
All right. Good morning, everyone. I am going to go ahead and get started, and I will apologize right now for my voice. I am a little congested, so if you can't hear me, if you'll just please put a message in the chat box so that I can adjust my speaking so you all can hear. So today what we are going to be talking about is understanding childhood trauma and past experience about how they shape health outcomes in adults, as well as looking at how we can change practice based on what we know for children as they experience trauma in their earlier years. So what we're going to be going over today is looking at the stereotypes of behavior in children and adults. We'll be talking about the Adverse Childhood Experiences Study, which really lays the framework for this discussion, and we'll look at high-risk behaviors, the early brain development, the impacts that trauma has on that, how we deal with different stress responses, and then really how this shapes how we look at treatment and outcomes for families, looking into the future. No matter which field you work in, it really helps to give us a different perspective of how we want to look at intervention with families so that we can have the best outcomes in their young years as well as in their adult years. So we're going to start out with looking at some just different information about Wyoming and our nation. So an estimated 681,000 children were confirmed victims of maltreatment in our country last year. And that equates to about 14% of the children in the United States suffer from substantiated abuse. We had 1,570 children who died of abuse and neglect in our country, and that is like the direct relation to abuse and neglect. That doesn't account for the children who might have been abused or neglected and died of something else that wasn't a direct correlation with abuse and neglect. We spend approximately $124 billion per year on abuse and neglect in our country, and that ranges anywhere from coming into the system and utilizing foster parents, utilizing services through the system, as well as any impacts on that child and family going forward into the future, like prolonged counseling or any of those services that go on for a long period of time. In 2014 in Wyoming, we had 898 victims of substantiated abuse, and of that, 347 of those victims were 5 years old and under. So we're seeing that about a third of the children right here in Wyoming are a very young age when they are abused. We spend approximately $1.5 million per month on services for children involved with the Department of Family Services. So that is not all-encompassing of everything that we're spending. That is just some of the reporting that is being done through the department in their particular series working with children. So what we do know that is good news about this is we know that there actually is a scientific link between what is happening to children at a very early age and how it impacts them as adults and their health as adults, which is what we'll get into talking about the Adverse Childhood Experiences study. So the ACEs study, it's often referred to, was a collaborative approach at looking at adults. So this looked at adults 18 years or older that were utilizing a healthcare system through Kaiser Permanente, which is a big insurance conglomerate out of California, and then a partnership with the Center for Disease Control, the CDC. So Dr. Bob Onda and Dr. Vince Felitti are the ones who put together this study to look at 17,000 patients through the Kaiser Permanente system who were having routine health screenings. And what they did was they provided this 10-question survey to these individuals, asking them about experiences that they'd had as a child. And really what it did was connected the dots for us. A lot of this information has been known for years, but this actually finally put some in with early trauma and adult health outcomes. So the survey is composed of just 10 questions that really looks at abuse, that being physical, looking at neglect, and then looking at household dysfunction. So they asked several questions around there that pertain to physical abuse, sexual abuse, emotional abuse, neglect, divorce, or parent separation, looks at domestic violence, looks at substance abuse, and incarceration. So with all of those questions, then they were able to make that direct link. For every question that you answered a yes on, you get 1 point on the ACEs questionnaire. Whoops, sorry. So this is a picture of the survey, and I realize it's really small print for you to see on your screens. But you can Google this. On the last slide was the link for that, and you can pull down the survey if you want to utilize that or just look at it. When I do this training in person, I have you as an individual take this survey for yourself, not to share with anybody in the room, but just to give you some insight about what your own ACEs score is, because we know we all bring stuff into our work. And it's really important that we know where we're coming from. And how we bring that to our work is really important, how we deal with it to ensure that we are not bringing too much bias into the work that we're doing. Sorry, excuse me. So you can see as you use this survey, you can also think of a child that you might be working with or have worked with. And although this survey is meant for adults, it still gives you a lot of insight as to what these children are experiencing in the early years and what their ACEs score is from a very early onset. I did this training last week in Casper, and there was an individual there who does some home visiting and works with children 0 to 3, and she had a 2-year-old who already had an ACEs score of 6. So that is really imperative to the message that comes out of this study, is that we really need to be aware of the children that we're working with, where they are landing on this scale, so that we can really drive appropriate interventions and preventions so that they don't end up on a very different path later. So when we look at the impact that the ACEs information has, we look across a bunch of different systems. And one of those is looking at the higher the ACEs score is, the more risk you have of the common diseases and common behaviors such as smoking, alcoholism, promiscuity, obesity, illicit drugs, IV drug use. Then when you look at the domain of general health and social functioning, the higher the ACEs score, there was more relationship problems, marriage to individuals who are alcoholics or substance abuse users, difficulty with job performance, high perceived stress, which we'll get into talking about stress here in just a little bit, mental health, poor self-regulated health, hallucinations, depression, sleep problems, memory problems, anxiety, anger control. And then we look at sexual health, higher rate of teen pregnancy, higher fetal death, unintended pregnancies, early age of first intercourse, and sexual dissatisfaction. And then the big one is here at the bottom, the prevalent diseases that we see in our country. The higher the ACEs score, really the higher these individuals are experiencing things such as cancer, liver disease, chronic lung disease, sexually transmitted diseases, and the number one killer in the United States is ischemic heart disease. And in fact, individuals who had an ACEs score of 7 or more have a 3.5 times more likelihood of ischemic heart disease. And individuals with an ACEs score over 4 have a 20-year less life expectancy than those with a 0 ACEs score. So we all have an ACEs score, whether that be 0 up to 10, and so it's really important for us to know what that is, like I said, bringing it into your work, but also knowing what trajectory you might be on for your health outcomes and things that we can do to intervene in that process. And I usually show a video which is done by Dr. Nadine Burke, who is a pediatrician out of California, and the ACEs information she shares has really changed her practice as a pediatrician at how do you look at these kids. She was getting a lot of referrals for children who were coming in for ADHD, and she really just felt she couldn't make that diagnosis, and so she started looking for more answers and came across the ACEs study and really found that it was not, in fact, ADHD. It was significant trauma that these children had experienced, which was a very different course of action that needed to be taken in dealing with the trauma as compared to treating them for ADHD. So it really has made some huge changes in the way that we think about intervening across our nation, and that's hopefully what you'll walk away with today, is really stepping back and thinking, how can you utilize this information in a different way? One other alarming statistic that is really important to share with you all is, as you all know, we have a really high suicide rate in Wyoming, and individuals have been found that have an ACEs score of 4 or more have a 12 times more likelihood of suicide. So this is really important for us to know. For instance, I said the lady who had the 2-year-old with an ACEs score of 6, we know that that little person at a very young age is potentially headed down a road for an increased risk of suicide. So what do we do from this very early age at 2 to start putting some things in place so that he doesn't become one of our statistics for suicide in our state? So it's really bringing some different awareness to how we think about these things. So what we look at is that when they did this survey, they found that 2/3 of the participants had at least one ACE, and they found that 1 in 8 have an ACEs score of 4 or more. A typical pediatrician in our country sees 2 to 4 children a day with an ACEs score of 4 or more. So that's pretty significant. In our state, we don't have a lot of pediatricians, so it's our general practitioners who are often seeing these children with high ACEs scores, and we need to be able to be aware of that to drive appropriate interventions very early. And I've already mentioned that the higher the ACEs score, the higher probability of poor adult outcomes. So what else have we really learned from the ACEs study is is that it does give the scientific proof to connect the dots. It's not alarming to any of us to know that when children experience trauma that there's some things that don't go so well for them later in life and they have a tendency maybe to make poor decisions. That's not new information for any of us, but what it did is it really gave a direct correlation to the higher the score, the higher the probability of things happening later in life. So what they found is that it was discovered that children who were under the age of 5 were at a huge risk, and like I said, here we had about a third of our children, and that seems pretty standard across the country. And then what was found was that 80% of these young adults who suffered abuse had at least one diagnosed psychiatric disorder by the age of 21. And then of these youth, they saw there was an increased rate of smoking, alcoholism, drug abuse, and they also found that there was a higher risk of sexual behavior, which then led them to higher risk of sexually transmitted diseases. These children were 1.5 times more likely to use drugs, 25% more likely to become pregnant as a teenager and suffer low academic performance. And this is where this crosses over many sectors. So these were young children, became juveniles who 59% of them had an increased likelihood of arrest, and of those 28% became adult criminals, and 30% of those became engaged in a violent crime as an adult. So this is not a child welfare issue for children being abused and neglected, and so that is one of the most important messages that is coming out of ACEs. This is a community issue. It's a systemic problem that we all need to have buy-in to and engage in because this affects many, many different areas. As you can see here, someone who experienced trauma as a young child has now entered into the juvenile system and has gone into the adult criminal system. There's lots of different sectors that we really need to be working cohesively with in order to prevent ACEs scores in young children. And then if we do have ACEs scores in young children that are high, we need to be able to intervene in an appropriate way so that we don't have so many adults then going into adult correctional facilities. So when we look at the research, there is also the Center of the Developing Child has spent a lot of time out of Harvard University looking at the developing brain of young children and how that is impacted by trauma in the early years. And so really, why is that important? Well, it's important for us to know that these traumas are happening for a third of the children at 5 years old or under. The majority of brain development happens in the first couple years of life, and by the age of 6, we start to prune off neuroconnections in the brain. So that means that as the brain is developing, children are laying down pathways in the brain, and those pathways, we know, become solidified by repetition. So if abuse and neglect is a repetitive behavior, we know that that interrupts typical circuitry of the brain, and those connections are the ones that tend to stay if it's a repetitive behavior. And those causative connections that are maybe not happening at all or that are happening very minimally are some of the connections that are pruned off. And so it's really important that we are laying down good physiological brain structure in these young children because we know after a certain point there is not a lot of opportunity to change that. So it's really important that we intervene early. And you can Google the Center for the Developing Child out of Harvard University. Jack Shankoff is a physician there who is doing a tremendous amount of research around early brain development and trauma to the brain. And there's just a wealth of information there. And this is a slide that really shows you what that developing brain looks like from a neurological standpoint. You see the brain of an infant does not have many connections yet because they get more of those as they grow and experience things. And then as you see, it looks like a tangled web, but it's very intentional tangling. when you have trauma, it interrupts those circuits in there, and so you get a broken up, tangled structure in the brain, which then does not function as well as a child who has typical neural connections happening. And so when we look at the newborn brain, it contains over 100 billion neurons. So a neuron is a brain cell. And 80% of those dendrites form after birth, and a large of them take place in the first 3 years of life. So there is a lot of push around early intervention and early experiences for children from birth to 3. And I would also argue that really it needs to start prenatally. There is a lot that happens prenatally to the developing child that we also need to be very aware of as well. And we already talked here about the pruning that happens, and that starts to happen by the age of 6. So it's really important. The earlier, the better. So this is a nice quote that has come out of the Center for the Developing Child. Building the capabilities of adult caregivers can help strengthen the environment of relationships essential to children's lifelong learning, health, and behavior. A breakdown in the reciprocal serve and return interactions between adult caregivers and young children can be the result of many factors. And we know that in our families. We know that there are many things that are happening in families across our country that are impacting their interaction with their children. And the most important thing with young children mentioned here is the reciprocal serve and return. And that happens in utero, that happens at birth, where there is really that opportunity to work with children to have that eye contact, that interaction, that back and forth conversation, even though it's happening through cooing and eye contact and body language. That is so essential from day one for infants to experience that. Children that experience severe neglect, that maybe are left in cribs, that always have bottle propping, this breaks down at a very early age and interrupts that circuitry that's laid down. So it's very important for that reciprocal serve and return relationship to continue throughout those early years. So when we look at what happens with these risky behaviors, the increase of ACE scores is prenatally some of the risk factors that we know have big impacts is smoking. We know that that decreases the fetal blood flow, which often causes a low birth weight baby, which can have lots of different determinants on health throughout their life. Also exposure to drugs and alcohol. We know fetal alcohol syndrome has really gotten a lot of publicity over the last few years because we're understanding that more of what that does to children and to the developing brain. Stress, and we'll talk a little bit more about that here in a few minutes, but that is really key, how stress impacts the developing child prenatally and mental illness. And then postnatally, we know some of those same things, smoking, stress, mental illness, and then a big one is domestic violence. We know that that's one of the #1 risk factors for abuse and neglect in children. And when we look at the Wyoming statistics, we've looked at some data through the Department of Family Services, and when we look at that, our highest incident for abuse and neglect is due to substance abuse, and then right underneath that is domestic violence. So it's very real, even in our own state. So why is it important that we really understand this component about trauma and the physiological impacts that it has? So I want you all to think about a time that you've either been really scared or that you've had anxiety that's lasted long term, and just think of how that makes your body feel internally and the physiological effects that happen. So for some of you, it might be that kind of tense feeling in your stomach or a sense of nausea. It might be tension in your shoulders. It might be migraine headaches. Thinking of how your body feels in that moment. Well, that's what happens to individuals who experience exposure to abuse and neglect, to that trauma. They have that physiological reaction that doesn't go away. then that becomes referred to as toxic stress. That is when this becomes very problematic. When that body is in that escalated height of reaction that we often fear, it changes the physiology by increasing hormones and different neurotransmitters through our body that start to cause changes. There's been a lot of research around cortisol. You all probably have heard of cortisol. It causes significant weight gain when that's secreted over a long period of time. And also that has an impact on breastfeeding for women who are breastfeeding. It drops their milk production. So there really is lots of components that happen to that prolonged stress response physiologically for us. But when we talk about that toxic stress and a stress response, this is really important that we're really aware of what does that mean. Stress is a very subjective thing. However, that is someone's reality, and we need to be very aware of that when we're working with families, is although what might stress me out might not stress you out in the same way. However, that is my reality, and my reality is that is causing a physiological reaction inside of me. Regardless of what your perception of my stress is, my body is reacting to that, and that is very real, and that causes changes inside our body. And when that happens over a prolonged period of time, it starts to impact our internal organs, which thus in return leads to those poor adult health outcomes. So when we look at stress, we need to really come from a point of view where we're not being judgmental when someone tells us about their stress level, because it is very real to them. So you can have different varieties of stress. You can have positive stress, which we all experience. That's kind of the stress that motivates us. So maybe you have a project due at the end of the day or the end of the week. Those are positive stresses. They motivate you and they go away relatively quickly. Tolerable stresses are stresses that last a little bit longer. So maybe it's changing jobs, and you have that learning curve at a new job that might last, 3 to 6 months, but then you kind of get a feel for the job and those go down. So it's a little bit longer term. It drops off. You don't have the long-term physiological responses from that. Toxic stress is where the problem is. What happens with toxic stress is that stress response goes on over a long period of time. And when that happens, you have the hormones and the neurotransmitters that change physiological interactions in our body, which then in turn leads to poor outcomes such as heart disease, lung disease, cancer. It stimulates those other cells that cause reactions in our body that cause long-term health problems. So that is where that direct correlation is, the linkage between the trauma and the later impacts on our health. So this just goes through to describe some things that you would think of under positive stress. So in young children, when you look at that, young children get frustrated, throw tantrums because they can't express themselves. And it's really important that we help families understand that. That often can lead to abuse and neglect when families don't understand the right expectations of children developmentally. It's normal. In fact, children under the age of 2 have a conflict every 3 minutes. That is a lot, but that is typical development, and we have to help people understand that. Beginning school is a positive stress. A project where it's really important with stress is having that social emotional buffer so that they can return to baseline. And many of our children who experience abuse and neglect don't have that. So they don't have the opportunity to lean on adults in their families or their homes that can help buffer that for them and help them learn how to cope and work through that. So their baseline becomes very different than a typical response that we would want to happen, to where those hormone levels drop back down. So then when we look at toxic stress, like we've already talked about, that's longer lasting. It causes physiological changes in the body and in the brain, and that is where that direct link goes into the ACEs study. And they too have those inefficient social emotional buffers to be able to really work through different things. So we often see children and families who have experienced abuse in their home or have toxic stress for whatever reason don't have any means of bringing themselves back to a normal baseline. And in some cases, they might not even know what a normal baseline looks like. So that's where we can intervene and help those families start to understand what that looks like. So what does that mean for us? And I know that there are individuals on here from very different perspectives in our communities, which is good because I really think this information is important for everybody to know. Everyone needs to have some ownership of this because it really does impact our communities, and it is not a one agency, a one person issue. So really to impact families is we need to have a clear understanding of what early exposure does. We also need to understand the importance about the family dynamic around chronic stress and what happens with that. We need to make a real effort to get involved earlier. We want to prevent these children from even entering the system, or we want them to go into school ready to learn. We really need to be able to get in front of this issue in a preventative way instead of a reactionary way. There also is a great toolkit through the World Health Organization, and the reference is there for you. You can go on to that, and it's called Preventing Child Maltreatment, A Guide to Taking Action and Generating Evidence. It's a great toolkit that was produced to really take a more in-depth look about what can be done at the community level. So then the question becomes is how do we make a difference? I really believe the first step is that we need to take an honest look at what we're currently doing and how that compares to the information that we know. This is not easy. This requires a lot of self-reflection, which sometimes is not easy to do. And there's a tendency in society where we typically can make a choice to continue doing stuff the same way because it's what's been done for the last 20 years. That is the cycle that we need to get away from. We really need to take a look at what we're doing and honestly ask ourselves, is this working? And if it's not, what do we need to do differently? And how do we use this information that we're learning from the ACEs study to do that differently? And the only way that we can do that is if we work collectively across groups and if we're willing to come to the table being honest about what is out there, how it's working, and how we can change it, which really requires a commitment. And sometimes that's easier said than done, I realize. But until we start making those steps, I really feel we can't make a true difference in working with young children and families to really change the trajectory of that. So there is a pediatrician whose name is Dr. Gardner, and he has a theory on that about how we can really start looking through a societal lens about doing things differently. And so he has a proposal about what we are currently doing and where we need to go. And so I'm going to walk you through what his theory is, and I really think this is a great approach that could be and should be looked at. The first, when we look at how we do things in our country now, is we invest very little dollars in prevention, and we already talked about that in the very beginning of this presentation about where our investments are lying. So what we know is the net for prevention is very small. Universal primary prevention is your messages that go out to the general public. So programs that are for anybody and everybody, your billboards that you see, really that just primary awareness messaging. And it's a small net that we typically cast right now. And so as you see, we have a lot of people who fall off of that. So then we cast a little bit bigger net with a hole in the middle that becomes our targeted interventions. So these are really looking at our high-risk groups, people who are experiencing low income, people who are using substances. These interventions start to get a little bit more targeted, and our net becomes a little bit bigger. However, they're not typically very individualized, so they're more of those things that address a target population. So we have a lot of people who fall off of that. Then we cast our biggest net and make our biggest investment in evidence-based treatment. Our biggest investment is when something has already happened. So we are very reactionary instead of being proactive. And again, you cast your last net bigger, becomes more individualized, but by this time we've experienced a lot of trauma, and we still have individuals who are falling off of that at the bottom. So that talks about that. So what his proposal is for us to really frame it and shape it in a different way, and that is to really look at the social emotional safety nets. So his theory is to really cast our biggest net at the beginning. Our universal primary prevention measures should be our biggest net that we cast, so that we are catching more people from the beginning. We're catching things before they happen. But again, we know that there's a ceiling effect to that, right? We know that we can't catch everyone with that. So his thought is then we keep our targeted interventions in the middle where they should be. Those are working with our high-risk groups. That's bringing in home visitation services, early literacy programs, parent support groups, parenting programs, different things that target individuals who are at risk that we can help. And when we look at risk behavior for child abuse and neglect, it is wide-ranging. It doesn't happen in one socioeconomic group. It doesn't happen in one ethnic group. It happens across the spectrum. And so we really need to target these interventions at the at-risk groups, but I think it's very important that these services are universally available as well. We still have individuals who fall through the net here, but what we end up with is a very targeted net to catch them on, is our evidence-based treatment. We know it works. We know there's individuals who need this very specific treatment, and these are your very specific psychiatric treatments, your substance abuse treatments, your drug courts, very specific targets to how they intervene with these individuals who have fallen through the other nets. But now we can target it very specifically to those individuals. And now we're only having to really invest our dollars at this level is very important, but we're not investing it in that big net at the top. It's for the individuals who really need it, because we caught people much earlier on in this process. So when we really look at that, and we talked about we need to take an honest look at what we're doing, is we need to really base things off what we know. So what we do know is that 95% of the trillions of dollars that we spend on health is on treatment and not prevention. Okay? So we know we're casting that big net on treatment and not on prevention. And what we know is that 70% of early deaths are preventable. That's huge. I'll give you an example. Alaska has done a lot of work with the ACEs research, and they had an issue, I believe it was back in 2008. They had the highest death rate in young children in the United States. They were #1 for young deaths. Then this last year, over the years, they've implemented some very specific programming. They have a high Native population with, I believe, 20-some different Native tribes in Alaska, and very poor access to health care and other services just because of the rural nature of Alaska and the weather. And so what they were finding is they went out into the bush to talk with families and talk about, what was happening, what was really causing these high rates of death, and finding out that a lot of it was access to care. They couldn't get in to access services, or there was a philosophy in their villages about birthing at home. And so what they've done is they've instituted some more services around their birthing hospitals in Alaska. They are building a Ronald McDonald House next to one of their big birthing hospitals, and they bring these families in from the bush during their pregnancy whenever they can get in. Might be 28 weeks, might be 30 weeks, might be 34 weeks. Whenever they can get in, they bring them into the Ronald McDonald home there where they can stay for free until they are ready to deliver so that they can monitor good birth outcomes for the child and for the mothers. And so this last year, Alaska has changed their numbers from the death rate. They are now number 1 on the positive end. So they went from the absolute worst to the absolute best in their death rate. So there is change that can be made, and we just have to take an active role in making that happen. And I think that they're a great example of that, especially with the rural nature, which tends to be something that we struggle with in Wyoming as well. We have a lot of space in between communities and difficulty accessing. But we also know that individuals, this last point here, that 70% of early deaths are preventable, we know that an ACE score of 4 or more takes 20 years off of life expectancy. And there is something that we can do about that and change those numbers. So I would challenge all of you as you think about this information to really think about what your piece is in that picture. And so when we look at having this information, now what do we do with it? So there is what are called the protective factors. This is some research that has come out through Strengthening Families initiative that really looks at now how do we go in and start to address this from a preventative end of things. And the number one thing is really looking at parental resiliency, really looking at helping parents to figure out how to cope in different situations, giving them those skills. Many of them don't know what that looks like, so how do we go in and help support families who have a very low social network and don't have those skills of knowing what to do. The second one that leads into that are social connections. Oftentimes, especially when we look at domestic violence, which is one of our huge precursors, is they're isolated, and that's an intentional thing that happens. How do we help break that cycle? How do we really help families who live in rural Wyoming to have those social connections, especially when there is a lack of transportation in many families? So really thinking about how do we do that and how are we intentional with that to get families connected to create a social network. Another one is building knowledge of parenting and child development. It's really essential that parents understand what to expect from their child. There are certain things that children cannot do because their brains are not developed to do that. We don't expect a 14-month-old to be potty trained, but some parents don't understand that, and that can lead to abuse and neglect. So how do we help inform them about appropriate child development, not only to prevent abuse from frustration, but to also help them engage in positive interactions with their child and have that good reciprocal serve and return relationship with them, to know what play is appropriate at what age. The next one is concentrating on supports in times of need. How do we get families linked to resources? Sometimes we struggle in Wyoming of not having all the resources that we need because of small communities, but how do we maximize what we have? The first thing is knowing what you have in your community, and the second is how do you get families connected into that? And then the last is social and emotional competency in children. Not only do we have to teach parents how to cope, we also have to teach that in children. How do we teach children to speak up for themselves? How do we teach them to have appropriate interactions with their peers? And part of that is knowing what that peer relationship should look like. We shouldn't be expecting young children to be playing cohesively together. That doesn't happen. They play independently, then they go to parallel play, and then they go to cooperative play. But we really have to understand that and help children move through those different components of that so that they really grow and mature appropriately in their social development. So there is a great resource for the protective factors training. We at the Wyoming Children's Trust Fund are going to be sending a couple of people to the Train the Trainer that will happen in New Jersey in December, and we'll be bringing that back to the state to do some Train the Trainer workshops that we'll hopefully be doing regionally. In the meantime, there is a training online that is through the Children's Trust Fund Alliance, and the web link is right there. It is free. It is 14 hours of training. It's extensive, but it is excellent information for you and your facility to work through. You don't have to block out 14 hours of time. You can do these. They're broken down into different modules, so you can take it over a period of time to work on it. And I would recommend looking at this in your organizations to really have at least maybe someone in your organizations participate in that to really get a good handle on how this can be used to support families in your area. This is just a favorite parable that I put in here. It says, a man by the river hears someone drowning. Being a good swimmer, he rescues the person. Before catching his breath, he hears another in need and another and another. The man, exhausted, begins to walk away. Asked where he's going, he responds, I'm going upstream to prevent the others from falling in. And I believe that this is what we all have a responsibility to do, is we all need to get upstream and help these individuals before we fall in. And then we also need to have good services for them available if they do fall in. And how do we help get them out of the water much quicker up the river than, you know, when it dumps into the ocean. So I think that this is a really important thing for us to be aware of and educate the people around us in our communities and help put programs in place that are really driven by our families' needs and how we can best serve them. And so when we look at what this means, is it's really having a balance. And really one great example of how we're doing that already in our state is around the prevention of sleep-related deaths. There's been a huge push for that in our state because we're one of the top 10 states for sleep-related infant deaths, one of the top 10 being not in the good top 10. But one initiative that is really working is increased education around safe sleep practices. Public Health and Prevent Child Abuse Wyoming are working together to get sleep sacks out to new families and information about how to have a safe sleeping environment. And we're really seeing a lot more knowledge out in our communities about how to help with that. And that is an issue for everybody who is going to be working with an infant. Because really our ultimate goal in all of this is for prevention, ultimately preventing injury and most importantly preventing death of very young children. And so that is the presentation that I have for you all. There are some good videos to link up to get more information. As I spoke about before, Dr. Nadine Burke is one of the videos that I typically show, and that is on YouTube. So you can just Google Dr. Nadine Burke and ACEs, and it's about a 17-minute TED Talk that she does. That's very, very informative. I would suggest going and watching that. Another video is looking at Dr. Shankoff's talk about neurodevelopment in the early brain, and that you can just go to the website for the Center of the Developing Child out of Harvard University, and there's lots and lots of resources there to tap into and be able to reference a lot of that brain development work that is going on. And so now I'd love to open it up for any questions that you might have. And we can have Cassie unmute the microphone, so if you have any questions, you can ask those either on the phone or you can type them into the chat box, and I'll be happy to answer any questions that you have.
Fantastic. Thanks, Jennifer. Also, we'll go ahead and bring up the evaluation at the end here, so while folks are still on the call, they can go ahead and do that. Looks like we've got a couple of questions coming in. Oh, good. lines are open if anyone wants to actually ask a question.
And so, Tricia, you are asking about the websites and the references for the videos, and we can absolutely get those up for you so that you can easily access those. They're really great resources to look through. Are there any other questions that anybody has?
Well, it looks like maybe not at the moment. Jen, thank you again for presenting this information again. We certainly appreciate it. We will post the webinar, the slides, and the recording on our website, and along with those links to the 2 YouTube videos that you mentioned. We'll post those. And if anybody has any questions or had any follow-up requests, just to let us know, and we'll make sure you get those.
And thank you all for attending today. I hope it was useful for you, and I look forward to being able to connect with many of you at some point. So thank you.
Thank you, everyone.